Okay, we're at the 7 o'clock hour, so we're going to talk about both upper and lower problems. When I send you the PowerPoint slides, they will also have links in them. There's a pretty good link, review of celiac, which we will not be going over. We will not spend a lot of time on interception because in your modules, there's quite a bit on that. So we will spend more time on things that aren't in your module. And then I have extra stuff within these slides when you get them that you can click on and see YouTube videos that I've streamed for you that are pretty good. So we'll go ahead and get started. For example, if you've forgotten anatomy and physiology, there is a good interactive site that I found, and it's right here on the screen, that will allow you to click and look and explore all on your own if you've forgotten any of your anatomy and physiology. It's kind of fun. Site, being interactive, pretty neat. Anyway, assessing a child for a GI disorder. So there's a lot of questions that go along with this. Abdominal pain is probably one of the more difficult things that you're going to have to try to figure out what is going on with the child. So we'll talk about some of those things that you would need to ask. Like, when did it start? How long has it been going on? Following what? Following a trip? Did you make a trip somewhere? Did you go to a new restaurant? What is it relieved by? What makes it feel better? Does going to the bathroom help or hurt? What makes it worse? Any changes in the diet? What are your symptoms? Do you have a fever or not with it? Has there been a change in bowel habits? And this is not so much like a change in bowel habits that you had when you were dealing with adults, but a change in bowel habits, the consistency. You're not necessarily looking for cancer here. You're just trying to figure out what it looks like, and perhaps pediatric nurses spend a lot of time looking at poop and determining the consistency, the color, the smell. We seem rather obsessed with poop. There is, by the way, a Bristol scale for poop. If you can look it up if you're really interested in how you categorize poop. I hung it up in the bathroom at work one time because it gave people a lot of kids and laughter. But anyway, so have they had travel? Have they been anywhere? Is there pain, and where is it? Does the pain change locations or remain in the same place? On a scale of 0 to 10, with 10 the worst, where are you? Little kids can tell you that. If they can count to 10, they can probably tell you where they are on the scale with a little coaxing. When did you urinate last? Have you had these problems before? Were you ever hospitalized for this problem? Anyone in your family have these problems? What medications are you taking? And what other medical problems do you have? These are all good questions to ask somebody that's coming in with a GI problem, abdominal pain. Tell me what you think the percent is for the amount of information that you can find from history. Out of 100%, what do you think the medical history consumed? What percent would you give it?
I'd say about 85%.
Anybody else? Honestly, it might even be more than that, because time you get through asking all the right questions, don't you pretty much know what's wrong with the patient? And doesn't examining them just confirm what you already found out from history. So a lot of people want, especially when you're just a brand new, student or nurse practitioner, you want to jump right in and do the physical part. You can't wait to lay hands on the patient. But the most important thing you'll do is the history. To ask the right questions, get the answers, put the pieces of the puzzle together, and then figure out what's wrong with the patient. 90% or more of the time that you need to spend with the patient is on listening their responses to your questions. Which of the questions in the prior slide would be most useful in this case? And I'll let you read it. What questions are you going to ask?
That's really good.
So you're going to have to speak. You're going to have to.
Busy.
What is it?
Busy.
What is it?
I would ask.
What's wrong with him, do you think? There's something in there that probably is throwing you off with what's wrong with him. And that something is he has had this before, but it eventually resolved. That could throw you off as to what might be wrong with him, couldn't it? Have you ever heard of chronic appendicitis? Some people do have chronic appendicitis. Of course, eventually they have to end up having an appendectomy, but they have bouts of appendicitis, but it doesn't evolve into anything surgical. So that's what's happened to Tommy. So what question would you ask? I mean, this is what they've shared with you. What do you want to know?
How long has it been going on for?
Right. Yes, that's an important piece, isn't it? Anything else?
What's the intensity on a scale of 1 to 10?
Absolutely. And what else?
Does anything make it better?
Yeah, anything make it better. I think what's making it better right now is lying with his knees bent, right? He obviously has some peritoneal irritation, or he wouldn't be doing that. And he, with appendicitis, you can have him jump or go from tiptoe to heel. And he says his right side hurts when he walks. That's a clue. So the clues for us here is nausea and some diarrhea. That can be constipation, by the way. Epigastric pain. It starts in the epigastric area. It moves down to the right lower quadrant. He has a low temperature, which, is normal for appendicitis at the beginning. He just doesn't feel good. He's lying with his knees bent, so his belly doesn't hurt. So those are all clues for appendicitis. Okay, the physical exam with GI disorders is to look at mainly, one of the big ones is the growth parameters, like the BMI, the height, the weight. Are they growing? Because with some of these GI disorders, they don't grow as well, like with celiac. They're usually short and underweight. The BMI, the height, if they're obese, hydration, inspection, auscultation, percussion, and palpation in that order. Peritoneal irritation, which our little Tommy had, and a rectal exam if it's needed. On a very young baby, you might want to know if there's anal atresia. On an older child, like an adolescent, you might be doing a rectal exam, feel for hemorrhoids. And then a GYN exam, if indicated, would be, so you first look, listen, percuss, and then palpate, light and deep palpation. In that order, or you stimulate the peristalsis. What will you think if child refuses to uncurl himself on the bed? Again, that's what we talked about already, wasn't it? Tommy, if he doesn't stretch out, then he has peritoneal irritation. And here's your little analog scale that you were talking about on a scale of 0 to 10. This is for little bitty kids who can't count, but certainly can identify the faces. Given the last scenario, what test are you going to order on that child? And here are all the tests you might order from somebody with abdominal problems. So what are you going to order on him?
CBC?
Absolutely, because we know in appendicitis it's going to be elevated, isn't it? Anything else?
CT scan?
You could do that. If he is as bad a shape as he sounds like from the scenario, probably if you're pretty sure after you do your exam that he's a potential appendectomy patient, you might want to ship him over to the ED. Why would you do a urinalysis on him?
Make sure it's not a urinary tract infection or a bladder infection.
And what, he had nausea, right? We don't know. He had diarrhea.
Nausea and diarrhea.
Yeah, we don't know if he ever had vomiting or not. But what, if you had a child that came in with vomiting and diarrhea, why would you do a urinalysis?
Check their hydration?
Yes, to check. It's an excellent tool to figure out if they have ketones, which would be indicative of dehydration, or their specific gravity was concentrated. Then those would be great tools. They're they don't cause any pain or anything. So those would be great tools to use. You might want to do a CMP, a comprehensive metabolic panel on him. But honestly, the way he's looking, I think I would be more inclined to, after the exam, to ship him across the way. Because what do we know about little children's appendix as different from an adult's appendix?
Perforation is more common?
Absolutely, because the skin is thinner. So it's more likely that it will perforate. and that is a 2-week hospital stay with IV fluids and survival if they're lucky. So if this child was having all this pain and then all of a sudden the pain went away, would you consider yourself encouraged or discouraged?
Discouraged.
Absolutely. You might have ruptured his appendix, right? So are you going to feel foolish if you send him over and they find out that really it was just indigestion?
Better safe than sorry.
That's exactly right. I can be foolish any day of the week, right? But I can't bring a child back that's died. So it's better to be safe than sorry. And this child, I think, presents with enough characteristic things that it would be good to send him on over. Okay, prebiotics and probiotics. Which one is a fermentable fiber that may have a role in diarrhea?
Probiotics.
Probiotics, right. Which one reconstitutes the intestinal flora, enhances the immune response, and reduces gut permeability?
Prebiotics.
So, and which one is used for irritable bowel syndrome and colic? You can answer this with one question. Which one is used for infectious diarrhea and antibiotic-associated diarrhea? You ever taken any probiotics for diarrhea? Yogurts and stuff like that. Some people use for probiotics. What's dysphagia? What is that?
Difficulty swallowing.
Difficulty swallowing, right. So Jamie is having trouble swallowing solids, but not liquids. Is this in your scope of practice?
No.
No. It's probably some kind of structural problem, isn't it? So what signs might you see in Jamie? How's she going to appear to you? What's going to be going on with her?
Weight loss.
Could be weight loss. What else?
If she's aspirated anything, she could have a cough.
Right. And if she's not swallowing, what's she going to be doing? She's going to be drooling, and she's not probably so much with this one, but with some other ones that have trouble swallowing. What nursing skill would you use most?
Assessment.
Huh? What'd you say?
Assessment.
What category of conditions causes trouble with both liquids and solids? It could be conditions like cerebral palsy, would have trouble swallowing, period. Could there be a problem between child and feeder? Should that be something you would be thinking about? It might be, mightn't it? A problem between the mother and the child, or whoever's feeding the child, could not be feeding them appropriately. Do you think a speech therapist would help you with this patient?
Yes.
Yes, because they do assess for swallowing, so it would be good to involve them in this child's care. What is the difference between vomiting and regurgitation? There are notes on these slides too underneath, so you'll have those too when you get the PowerPoint. What's the difference between vomiting and regurgitation? When you vomit, what do? Does it roll out?
No, it's forceful.
Right, that's the difference.
The velocity is a lot faster.
That's right, that's right. So what would you consider to be projectile vomiting? That's not your usual vomiting, is it?
No.
Projectile. It shoots across the room, right?
Yeah.
That's oftentimes seen with children with pyloric stenosis. They have projectile vomiting. It's not the normal vomiting. It actually has quite a distance to go. What kind of adjectives can you use with vomiting?
Bilious.
Right. And what other kind? What other kind of vomiting can you have, which would be really serious?
Intractable.
What?
Intractable.
Intractable vomiting? What Kate Middleton has with her second, and first child. What about bloody vomiting? Sometimes the prematures in the intensive care nursery develop stress ulcers, and they can actually vomit blood, and that's really scary. So dehydration is certainly one of the things that you have to worry about with children with GI problems. So if a child has lost 3%, 6%, or 15% of their weight, is that worrisome?
Yes.
It's all worrisome, isn't it? What is dehydration usually caused from?
Inadequate intake.
Uh-huh. Or excessive
loss.
output, right?
Yeah, diarrhea, vomiting,
Uh-huh.
fever.
Why are children at increased risk? How are they different from adults?
Is it just because of their size? They're
Right.
smaller, so
Uh-huh.
it
They
takes,
actually have more surface area than body mass, so they're going to lose liquids and fluids. And most of their organs are not working all that well, right? Kidneys aren't concentrating as well as they should. A lot of those things are just beginning to work. What is the difference between having diarrhea only, vomiting only, or both together? Which is the worst?
Both put together.
Vomiting only.
Vomiting is something that you want to stop. Diarrhea, your body, if you're taking in fluids and having diarrhea, you probably are going to be okay. But if you're vomiting, whether you're having diarrhea or not, you're not taking in fluids. So you definitely want to stop the vomiting. And in many, many cases, do not want to stop the diarrhea. Because if it's viral or foodborne, you want to get it out there. So it's more critical to worry about the vomiting. What is the most useful clinical sign of dehydration?
Capillary refill.
What?
Capillary.
Capillary refill. Absolutely. Fantastic. That's right. What is used in the clinical dehydration scale to determine degree of dehydration? And there's a whole list of these in your book. So what are you going to look for in a child that's dehydrated? How are you going to know somebody's dehydrated, in other words?
No tears.
No tears, right. Baby's crying, but nothing's coming out. What else?
No wet diapers.
No wet diapers, especially concerning if they haven't urinated in 6 hours. What else? How did you look when you had the flu? What did your eyes look like? You ever had viral gastroenteritis?
Sunken.
Yes, sunken. So what else would be sunken in a baby?
Fontanelles.
The fontanelles, right? And there is a whole list of it, and like I said, at the bottom of these slides, there are notes that will help you answer even better some of these questions. So the treatment for dehydration, it certainly has changed since the beginning of time that I ever knew it. We used to give children salt water when they were dehydrated. You can imagine that wasn't very helpful, but we've come a long way since the early times. And so one of the things that you can tell your patients, mothers, to give their children is Pedialyte. And there's your dose right there. But actually, on most of the Pedialyte, just a liquid electrolyte solution, and it's flavored in some cases. Most of the Pedialyte bottles do have, if they're English breeding, do have the doses on the side. This is something new to continue the breastfeeding. You might want to figure out, though, what the mother's eating, because sometimes that can give the baby diarrhea. Then you might want to take them off milk during this time, or even in a week, take them off milk, but kept the lactose-free one you might give as a trial to see if they get better. So once they're rehydrated, you can resume their normal diet. Then you can give them things like complex carbohydrates, fresh fruits, lean meats, yogurt, and vegetables are recommended. Avoid fatty foods, those high in simple sugars. No caffeine, no carbonated drinks or commercial juices. So the treatment for diarrhea has really changed, probably for the better, because we probably used to starve them to death for 6 to 8 hours to rest the bowel, and then we wouldn't give them, but very little of anything thereafter. So it's gotten a little bit more liberal and reasonable in the treatment. So, talking about dehydration, who are you going to send to the hospital? The child comes in. What's going to make you want to send them to the hospital?
If they have neurologic changes,
Absolutely, because you can get confusion and neurologic changes with dehydration, can't you? What else would make you think they need to go?
No wet diapers in 8 or 10 hours.
Oh, absolutely right. And how are they going to be looking to you?
Lethargic.
Absolutely. And when does a child quit playing?
when they don't feel good.
When they're almost dead. They will play. They will play till they absolutely cannot play anymore. There's a thing called cyclic vomiting syndrome. So this child, in between their intense vomiting episodes, they're fairly normal. Usually girls are more likely to have it, and it is a diagnosis of exclusion in that you have to rule everything out. Some of these children have anxiety and depression and can have Munchausen. You know what that is? Munchausen is when the parent or caretaker makes their child sick because they need the attention. And so they will come in and do things to their child. They'll give them things to absolutely make them sick, almost to the point of killing them, to get them to go to the doctor so that they can have the attention. So you can have stress and a lot of things precipitate it. That's it. But between the cycles, they are fine. It's really difficult to rule out, rule this in. Something that's given a lot of times for nausea is Zofran. So here's some dosing for you. Well, one of these is upside down. I don't know how that happened. 16 to 30 kilograms, 4 milligram dose. I really honestly do not know. That is a defect in their stuff. So you can refer back to this or put it in a little book whenever you are in clinical to kind of help you. That 7 should be 12 to 17-year-olds. 8 milligrams every 4 hours for 3 doses. Zofran was really used with cancer patients, and it has since been used to help children that just have vomiting from other causes, but originally its use was in cancer patients. And the little bitty folks below 8 kilograms can have it IV, but of course you're not in the tertiary, secondary roles, so.
I have taco soup Friday at work,
Huh?
and they had a list up for you to sign up to bring something. I thought I'm sorry. What is it?
So you said it used quite a bit.
What are you smiling
I'll
at?
still, I'd
I could hear
say.
you talking about this.
Wonder how.
There is a
You
thing
can't
called
study from
abdominal
college.
migraine. You ever heard of abdominal migraine? Is paroxysmal intense acute peri-umbilical pain for up to 72 hours. And then they have periods when they don't have it. It does interfere with their activities and can be accompanied by things like nausea, vomiting, anorexia, headache, photophobia, or pallor. And there's no evidence to support the problem. So the symptoms present 2 or more times in the last year, and there's a family migraine history that should give you a clue about this condition. And the children, I believe it's this one where the children are rather dramatic when they have the pain. So I think the best clue with this is that the family has a migraine history themselves. So if you have somebody that has abdominal pain but there's no real reason, then this is certainly a diagnosis that you would want to rule in as a possible cause for the abdominal pain. Peptic ulcer disease is something else that little kids have. Where are the primary ulcers found? What part of the intestine? Most of the ulcers
In
are
the
there.
stomach?
No, they used to be. They used to be in the stomach, but we're doing a whole lot better with taking care of our food. So they're usually in the duodenum area. And there's sometimes secondary ulcers are the result of a lot of hydrochloric acid in the stomach. Do duodenal ulcers run in families? They do. And so your history would be really important here to take. And the Zollinger-Ellison syndrome is just where they have an excessive amount of hydrochloric acid being poured into their stomach. It's a genetic problem with the usual symptoms for disease, peptic ulcer disease. What would dental enamel erosion or mouth ulcers tell you? If they had dental enamel erosion, what do you think that's from?
Acid reflux.
Yeah, GERD, right. If they had mouth ulcers, it would probably be more from like peptic ulcer disease. What would wheezing tell you? Why would somebody with a GI problem have wheezing?
They're aspirating.
They're aspirating, right. They have GERD and it's coming up and getting into their lungs. Then some red flags for systemic disease would be things like if you check for coagulation problems, if they have had some bleeding problems, or if their C-reactive protein was elevated, or if their white blood cell count was elevated, then you would be thinking more about systemic disease. So the treatment for things like we've been talking about is upper GI series are an esophagogastrocolitis, then endoscopy, which is a huge word. But they just go in and take a look and see some of the more reliable tests, I might say. Some of you had, somebody was telling me that you had H. pylori patients. Was that any of you all? No? Okay, A lot of people are probably treated for this, but there are some standards for diagnosing it, and these are the 4 ways to diagnose it. But if you do an antibody titer, it only means that you've been exposed to the disease. It doesn't really tell you if you still have it or not. And then a still monoclonal antibody that says that you're responding to the therapy. So one of the problems with detecting H. pylori is that you get a lot of positive tests that aren't really positive. So it's a little bit of a difficulty in diagnosing this. But the treatment is pretty effective. The management for pelvic disease is usually the H2RAs or the PPIs are your first line treatment. When should you give the PPI? Before you eat, right? And when should you give the antacid? After you eat. What determines the eradication rate? What determines whether they get better or not, do you think?
Compliance.
What determines if anybody gets better?
Taking their medicine.
Absolutely, compliance with their medication regimen. And these people are not all that compliant because most of the time they're taking 3 different medicines for anywhere from 14 to 21 days. When do you refer? Like everything else, when they don't get better with what you try. And what drugs are used to treat it. I think on the next slide we go over that. Who has the highest rates of mortality? The people that don't do good medicine. So, I don't know where it is on this slide. I thought it was on here, but things like clarithromycin and amoxicillin, omeprazole are some of the medicines that are used. Flagyl is another medicine that's used to treat H. pylori. What objects have to be removed if they're swallowed?
Magnets.
Magnets, absolutely. Magnets.
Battery.
Batteries. What else? Straight pins. Safety pins. How do you diagnose what it is besides the history?
X-ray.
X-ray, because most of these things that they swallow, they're opaque, radiopaque, and they'll show up. What should you not do?
Try to retrieve it.
Try to retrieve it. Absolutely. Good job. So here's a little boy, a little 6-year-old, presents to your clinic with abdominal pain that was initially around the umbilicus, and now it's drifted to the right lower quadrant. He vomited prior to the pain and feels nauseous but hungry. He says he feels warm and is walking bent over, holding his side. He won't let you feel his abdomen. He says the pain is getting worse, and he's so scared because he had a friend with the same kind of pain, and when it went away, he had to stay in the hospital forever and was very sick. So what are you going to tell James, and what are you going to do for him? First off, what are you going to tell this little 6-year-old? What's he need?
Reassurance.
Reassurance.
Absolutely. He needs reassuring that you're going to take care of him. You're not going to let anything happen to him. But that what? You might what? After what? Are you going to have to send him to the hospital?
Probably.
Yeah, I think so. So you're going to have to tell him what might happen to him when he's over there. A little bit of what might happen to him while he's over there. Not enough to scare the life out of him, but he does need to be warned that you're sending him to a place where they're going to take care of him and make him feel better. Functional abdominal pain, some people have. It occurs at least once a week for 2 months, for the past 2 months, and it can be episodic or continuous. There's usually nothing there to cause it, but there is a family history of it. Sometimes people think it's secondary gains or associated symptoms, can be anxiety and depression. Reported abdominal pain accompanied by dramatic reactions, symptoms worse in the morning, and you need to think about illicit drug use or sexual abuse. I had a 10-year-old little boy that had this, and it was very dramatic. He would be standing at the bed in the clinic, in the room, and all of a sudden he would bend over, fall to the floor, and wreath around with agonizing pain. And it was something to see. It was almost Academy Award winning. And the mother wanted him to have a colon resection, no less, for his abdominal pain. And she had been to numerous providers who hadn't told her that anything was wrong with this little boy. And he told tales of he was homeschooled, surprise, surprise, because sometimes secondary gain is you don't have to go to school if you're really in bad shape. So he didn't go to school. He was homeschooled, and his rendition of his homeschooling was his mother made him do the laundry, sweep, and mop all day long while she sat on the couch. So it was an interesting case. You couldn't really determine. I finally got her in therapy because I really was concerned about Munchausen. Irritable bowel is another GI problem where the pain really gets improved with defecation, and the form and appearance of the stool change. And the one thing that I've noticed about people with irritable bowel is when they actually are full-blown in their attacks of this condition, the stools actually float on the water. Normally stools sink, but these float. They have a lot of anxiety and depression, bloating, dyspepsia, family history of irritable bowel syndrome. So, have any of you ever eaten a lot of that sweetener, any of the sweeteners? If you have, then you know that they cause diarrhea and bloating and a lot of gas. So that's to be avoided, along with caffeine, fatty foods, carbonated beverages, milk, things like cabbage, cauliflower, all those things that are good for you. So the treatment is peppermint oil or things like Imodium, antispasmodics like Ventolin, antibiotics, amitriptyline, and serotonin reuptake inhibitors for their depression and anxiety. And a lot of them go into therapy like cognitive behavioral therapy, yoga and acupuncture, hypnotherapy. There's a mind-body connection here, as there is with most things. Celiac disease, here is your connection to learning about it, and the girl that does the tape does a really excellent job of the reason for it and the treatment and all of that. And the same thing with lactose intolerance. Some really good things for you on YouTube. What do you do if you see a child with polyps? Is that something you can deal with?
Mm-mm. Refer them.
Refer them, right. What should you do if you see a child with anal fissures? And what should be in the back of your mind if you see anal fissures?
Sexual abuse.
Absolutely. You can use steroid cream and on them to kind of help that heal. Here's Crohn's disease, another great YouTube video. Short, most of these are short. So what is the definition of failure to thrive? Your book gives a really good, simple definition of that.
Not gaining weight.
It's when the height and the weight are not normal for the age. They're below the median, sometimes below the 5th percentile, or they've crossed over 2 major percentile lines. Crossed over meaning they're deteriorating. What can cause failure to thrive? What can cause you not to grow? It's the same thing that can make you dehydrated. Remember, you gave me some good examples of that.
Kids not having enough intake.
Yeah, not enough intake,
Too much output.
too much output, can cause you not to grow. Why might we be seeing more of failure to thrive than we have in the past, do you think?
Drug addiction.
Right? Yep, the parents are using drugs and therefore not able to take care of the children. And preemies are surviving, aren't they? So preemies are going to have some amount of failure to thrive. Between 2 weeks and 4 months, it's probably due to congenital problems or problems with the mom and baby interaction. But from 4 to 8 months, it's usually feeding problems. And everything from the head, height, and weight may be affected. And there's a lot of systems. If you're not feeding your systems, body, a lot that won't work well. And here's your failure to thrive lecture that's good. Hey, what I'm going to do is I'm going to send you by your email some case studies on the different types of diarrhea and see if you can identify them. I'll try to do that tomorrow or Wednesday and just give you some by your email, some cases, so you can kind of see if they, if you know what they cause from. But the most serious are caused from food, and my husband, I know, ate some hamburger. It had E. coli in it, and he ended up being very sick and almost dying. He had really bloody diarrhea. He had so much bloody diarrhea that they had to give him several blood transfusions. And then he had a heart attack because he lost all the blood. But that was good because we found out his widowmaker was almost closed. So he lives today because of his food poisoning. But anyway, it can cause weight loss and dehydration, and anything lasting several days with more than 3 stools a day is serious, especially if you get neurological involvement or blood like he did. Less serious would be absence of a low-grade fever, mild pain, and watery diarrhea, not with blood in it. Would be. That's good. And then your book gives you charts upon charts of different kinds of diarrhea. And I'm going to try to point out the ones that are most significant, their symptoms. So lots of diagnostic tests for diarrhea. Most people do a stool culture, and probably if they're in the clinic, it'll only be one. But the best rule is to do 3 on separate days. And then you can see all of the things that you could order if the diarrhea persisted. And you will have all these slides, so don't worry about you're able to catch up with it. I have found some absolutely fantastic, I mean it, videos on intestinal parasites. I found 2 that are absolutely fantastic. But I wouldn't eat right before or maybe even after you watch them, but they're embedded in this PowerPoint. Most of them are caught by fecal-oral contact with the eggs. A lot of times the cysts are in water and food, or you can walk barefooted on contaminated soil and get some of these worms. Most of the time it's in countries with poor sanitation, and the best way to prevent it is good hand washing and good sanitation. What I need to find for you is one on pinworms, because that's not one of the worms that's listed. The prevention is to eat, if you're in a foreign country somewhere, peeled or cooked soup, wear shoes, drink or brush with bottled water. If you're going to Africa, for example, and you might not be after you see these videos, but if you go there, then those are ways to prevent having intestinal parasites. So there are actually 4 YouTube videos to introduce you to the deadliest parasites in the world. And we do get travelers from Africa, from Asia, and from other places, and sometimes they do come with their parasites. They're not screened in airports. So you will be amazed when you see these YouTube videos. They're just awesome. And here's all the different worm medicines. So if anything, you would need to just recognize their names to know that they're worm medicines. And a lot of them, have GOLE on it, but not all of them do.